Good morning. I'm Nicole Hale. Thank you for joining us today for this Whittier Trust and Keck Medicine of USC webinar. Thanks to our longstanding relationship with the Medical Center, we're excited to bring you useful information from our partners at Keck Medicine of USC. Today's topics will focus on tips for optimal and joyful aging, heart health, eye health, and Alzheimer's prevention. We want to give you the opportunity to get your questions answered, so we will reserve time at the end of the presentation for Q&A. You may enter your questions at any time in the Q&A box located in the top right corner of your screen. It's now my pleasure to introduce Dr. Robinson, Professor and Chair of the Department of Family Medicine, President of USC Keck Medical Group, and Associate Dean for Primary Care. I'll now hand it over to you, Dr. Robinson.
Good morning, and thank you for joining us this morning. I'm delighted to be facilitating a panel discussion with three of my esteemed colleagues on innovations in aging well. Before I introduce my colleagues, I'd like to give you a bit of background on Keck Medicine of USC. We are a growing health system with 3 hospitals and 80 clinics across Southern California. We have a team of employees that is ready and willing to care for our patients, and we pride ourselves on caring for 245,000 unique patients annually. What is unique about our health system is, in addition to our 3 hospitals, we also have Keck School of Medicine, where we are training the next generation of healthcare professionals and also conducting cutting-edge research in a number of areas, some of which you'll get to hear about today. We pride ourselves on the national recognition that our health system has received from U.S. News and World Reports. We are ranked top in regional hospitals, we have national ranking, and we have excellence and expertise in ranking in several specialty areas, including those that you're going to hear about today, where we have top ranking in the areas of ophthalmology, neurology, as well as cardiology. We are an aging nation, and 2030 is thought to be a pivotal year for our country. It'll be the first time when the number of adults who are over age 65 exceed the number of children under 18. 1 in every 5 residents will be of retirement age, and our population distribution will change from being a younger population to more of an older population, as you see on the right. We know that our older adults have more health needs. It's estimated that 80% of adults over 65 have 1 chronic condition, and the vast majority have 2 or more chronic conditions. As we age, every part of our body is impacted. We know that 92% of our older adults have vision problems. There are impacts on the heart, impacts on the brain, and we're going to get an opportunity to hear more about that today. In the past, we had thought about aging as something that we should fight against, something that we should battle. And when we thought about what we could do about aging, the idea was really not much. We just have to put up with it. But with a new lens, we are embracing aging as a time of continued growth and transformation. We know that our older adults have so much in the way of wisdom to share with us. And we know that there is much that we can do to ensure well-being as we age. And as a family medicine physician, I'm delighted to practice at Keck Medicine of USC, where I have access to phenomenal colleagues that we're going to get to hear from in a moment that can help my patients stay healthy as they age. So I'd like to first turn it over to Dr. Humayun Yassin, who is an associate professor in the departments of medicine and neurology, to share with us about protecting the aging brain from Alzheimer's. Dr. Yassin.
Thank you, Jenny. It's a pleasure to be here, and we are excited to present our work in front of you. Happy to take your questions, and hopefully we get to engage with you and explain what we're doing in a clear way. So my lab, my background is I'm both a an internist and a neurologist, and I study the intersection of how the diet, lifestyle affects the brain. Specifically, I have a deep interest in the mechanisms that lead to Alzheimer's disease. Advances in genetics over the past couple of decades have shown that carrying the ApoE4 allele is a significant risk factor to developing Alzheimer's disease. Unlike other variants, ApoE4 is quite common. In fact, 1 out of 4 people carry 1 copy of the ApoE4 allele. So if we look at the population as a whole, if we assume there's about 350 or 300 million Americans at the moment, 75 million individuals have 1 copy of ApoE4, and a lot of people are finding out when they're doing 23andMe. Now, when we study patients with Alzheimer's, up to 50 to 60% of those patients carry 1 copy of ApoE4. This tells you how much this is a significant problem to developing Alzheimer's disease. You can get 1 copy or 2 copies of E4, depending whether both mom and dad carry E4. And importantly, in this day and age, despite all this genetic information, we lack recommendations on what's the right diet, the lifestyle, or even drugs that can protect the aging brain in ApoE4 carriers. So let me just walk you through, just in a minute or so, what we have been doing over the past decade at USC. So, my lab has shown that lower omega-3 levels are associated with worse cognitive function, smaller hippocampal volumes, and more amyloid plaques in older adults without Alzheimer's. We have also shown that E4 carriers with Alzheimer's have reduced omega-3 brain delivery, so just explaining why omega-3 supplementation does not have an effect in ApoE4 carriers with dementia. Then we identified that in patients with dementia, an enzyme is activated that breaks down omega-3s in ApoE4 carriers. And we're working with different groups within campus to develop a drug that can block this enzyme to help ApoE4 carriers use omega-3s when they develop neurodegeneration and dementia. We have used novel PET imaging studies to track down how much omega-3s can get into the brain, and we labeled omega-3s by radioactive compounds that can light up, and found that younger ApoE4 carriers in the 30s have an increase in brain omega-3 uptake. This suggests a greater brain demand for omega-3s in this 30, 40-year-old younger ApoE4 carrier. And also this implies that an omega-3 deficient diet in a younger ApoE4 carrier may not be helping the brain. We also found that ApoE4 carriers, before they get dementia, they have less delivery of omega-3 to the brain, and used that concept to launch the Prevent E4 trial. The trial started in 2019, is ongoing till 2024, where we're trying to test whether higher doses of omega-3s in ApoE4 carriers can slow down the progression to Alzheimer's. So this is an example of what my lab has been doing over the last decade. And we want to take this 1 notch up. So our goal over the next 5 to 10 years is to build a resource for ApoE4 carriers. We want to develop a system based on individualized omics advances, where we could tell, you have the ApoE4, this is the diet that you need to eat, this is the exercise that you should be doing. We want to study different gene variants in ApoE4, different lifestyle, sleep, diet, and possibly the microbiome, where we take the stool to understand how the diet is affecting the brain. Our goal is to study individuals across the lifespan, because you are born with ApoE4, and by the time you get Alzheimer's, it might be too late. So there's decades where we could intervene to mitigate the effect of this gene variant on the brain. And ultimately, we also want to develop drugs that can inhibit the pathways in ApoE4 carriers with dementia to allow this brain inflammation, because we've also shown that ApoE4 with dementia is associated with a high degree of brain inflammation. If we can develop drugs to ApoE4 carriers that focus on how this gene variant increases the risk of dementia, I think we would have achieved a big goal that we are aiming for. So I want to acknowledge, our funders, our collaborators. Mike Vranos has been quite supportive of our effort to develop drugs for ApoE4. The Alzheimer Association, the Alzheimer Drug Discovery Foundation, the NIH for funding us, and the many collaborators. And more importantly, my lab that has been able to, support all the studies that you have shown. So I'm going to take the next, time to introduce our next speaker, Dr. Mark Humayun. Mark is a professor in ophthalmology, biomedical engineering. He is the director of the USC Institute for Biomedical Therapeutics and the co-director of USC Roski Eye Institute. It's my pleasure to introduce Mark.
Well, thank you very much, Hossein, and good morning to everyone for attending this conference. And I'm happy to share how the eye ages and some of the exciting things we're doing to prevent this, ameliorate it. So many of you, here's a picture of the eye. Many of you may be familiar with it. The front of the eye is the cornea, and inside the eye is the lens, as you can see. And the cornea and the lens work together to focus the image on the back of the eye, the retina, the orange tissue. And then the information is processed and sent via the nerve, the optic nerve, to the brain. Now, we've all heard about cataracts. This is a major issue as we get older. 24.4 million in the US alone have this cloudiness of the lens, which is the cataract. And half of the Americans aged 80 or older have cataracts or have had surgery for cataract. So this is a condition that is of aging, but fortunately we are able to address this very well through surgery. Now, switching to glaucoma, which is an issue, which is the second leading cause of blindness, and there's 3 million in the US that are affected. And this risk also increases with aging, and it's because the eye pressure goes up. Now, the eye pressure is not related to your blood pressure, so it's different, but it does, unfortunately, affect the eye, damages the eye, and damages the optic nerve, leading to blindness. And currently, we can slow it down with eye drops. Some of you may have heard of people taking glaucoma drops or even laser or surgery. But again, there's really no cure for this. So this is a condition that is related to aging that we're working on and trying to improve. An area where I've been working very closely is those diseases that affect the retina. Now, if you look in the back of the eye, as I mentioned, the orange tissue is the retina, which processes that focused light and converts it into pulses. And you can see here a picture of the retina. And in the very center, the part you read with is what we call the macular fovea. And age-related macular degeneration, or macular degeneration for short, or AMD, is a big problem that's related to aging. 15 million in the US are affected by this, 1.7 million are blind. And what this does is create blurriness in the very central vision. So no matter where you look, you see this black spot. You can't see faces, you can't read, you can't watch TV, you can't drive. And there are two different types of it, the dry and wet. The wet, by that we mean the bleeding type. And we can slow the bleeding type with eye injections. I'm sure those of you who know somebody who is older and has macular degeneration may be getting these injections. And there's some vitamins to slow down the dry macular degeneration. But again, this is a big issue for the aging eye that I'm working on, and we'll show you a video about this, how we're using stem cells to potentially offer a treatment for the dry macular degeneration. And then diabetic retinopathy is something that affects patients with diabetes, just as it affects your kidneys, your peripheral nerves. It also affects the eye, the retina in particular. And there are 10 million in the US currently, and this is growing as diabetic population is growing, and can cause visual loss by bleeding blood vessels in the back of the retina. Again, we can use eye injections into the eye, just like we did for the wet macular degeneration, to slow down the vision loss, and laser and surgery can also be used later on. But again, this is an issue that we want to address and be able to deal with. And because diabetes affects more the type 2 diabetes, which is the adult onset diabetes, we see it again more in the aging population. So with that, where are we with this? We sort of come to address these issues through a four-pronged approach. Dr. Robinson was kind enough to point this out, that our ophthalmology program here has been one of the tops in the country. Actually, we're ranked #1 in research by the National Eye Institute, which is a part of NIH, National Institutes of Health. We, of course, pride ourselves in educating, as Dr. Robinson said, the workforce of the future, the medical students, the residents, the fellows. And we also are very involved in community care through providing primary care, for example, for the underprivileged through the LA County Hospital. So again, this patient care, research, education, and community is our mission and what we've been working on in ophthalmology. And I think now, and we've been fortunate enough over the years to get our research programs have won some great awards. Here I was fortunate enough to receive the National Medal of Science and Technology from President Obama for some of our work. Some of our work has been featured on the cover of National Geographic and other scientific journals. So again, we're very fortunate and great to be here at USC to be able to make this difference for people who do suffer from blindness, in particular blindness of the aging population. And so I leave you with the story, and this is what it's about. At the end of the day, as a physician, as a scientist, we want to make a difference in a patient's life. And here you will see a video coming up where a patient was blind, she was struggling, and how we were able to help her with a new development that we came up with at USC Roski Eye Institute. So we could play the video, please.
My name is Anna Kuhl. I have lived in Southern California since, oh my goodness, since I was 22. In the beginning, I didn't notice anything different for a long, long time, except that my vision deteriorated and I needed stronger and stronger glasses. All of a sudden, I saw this big black area, and I was so surprised and scared that I called USC, the Eye Institute, right away and made an appointment for the same day.
Anna Kuhl came to us really looking for an advanced new technique to restore her sight. She had been going blind from a condition called macular degeneration. So what happens in this condition is the retina, which lines the inside of the eye, has light-sensing cells called rods and cones. And in this condition, macular degeneration, the rods and cones get affected in the center of the retina, the part that you read with, recognize faces, and watch television with.
When I realized that I have dry macular degeneration, my vision was still pretty good. But as time went on and I lost the cells.
Then that area becomes atrophic, meaning completely degenerated and destroyed. So you end up with a black blind spot. Wherever you look, there's this blind spot. So if you try to look at somebody's face, there's a blind spot. If you try to read, there's this blind spot.
When I lost the central vision in my left eye, I had to give up many things that I used to do. I became dependent, much more dependent on other people.
What we came up with is the concept of just replacing those aged and missing cells using stem cells.
We've gotten to the point where we can differentiate stem cells into actual mature adult RPE, which is the exact cell type that's missing in the patients. So what we do is grow those stem cells into the RPE in the lab on a dish and grow them on this very thin layer of parylene or plastic.
Our innovation has been to engineer a scaffold that is able to carry these cells in and able to be implanted in the eye and seamlessly integrate with the eye, because it really does need to do that latter part.
So it's essentially the cells that are missing in the exact anatomic configuration that they should be in when they're delivered to that space.
After the procedure, my life changed in many ways. I could tell so soon afterwards that something was happening in this eye. When I could see whole faces on the TV, and also the whole face of Hans, my husband, and other people, because I had a very hard time recognizing people before. If you don't recognize people, you don't even like to go to parties or anything, and now I like parties again.
Well, hopefully through that small video, I've been able to share something that we've been able to do at USC. Makes a big difference for me and our team to even help one patient like you saw with Anna. And, now we're going to take this procedure that was only done at USC and start doing it at other centers. This is an investigational study, so it's not an approved therapy. We're going through the different clinical stages. But in conclusion, what I've shared with you is that vision impairment and eye diseases really do occur in growing numbers due in aging population. And there is, although I didn't touch on it, there's a disproportionate incidence in minority populations. And as I mentioned, there is a significant comorbid condition for example, associated with this epidemic of diabetes. Many great ideas like the one you just saw require philanthropic seed funding to show proof of principle in order to obtain these larger grants, which you can then get from the NIH or the state or corporate funding and ultimately benefit patients. So seed funding is so critical. And at USC, with the help of philanthropic funding, we've been successful in launching new breakthrough ideas like the one you just saw. And so I conclude by listing some of the organizations that we're very grateful to the support of not only the federal NIH, National Eye Institute, National Science Foundation, and the state, the California Institute of Regenerative Medicine, but also these philanthropic seed funding sources such as Dr. Allen and Charlotte Ginsburg, the namesake of our institute, Michelle and Dennis Levinsky, the Perkins Foundation, and of course, we also had gotten some grants from the L.K. Whittier Foundation, which were very critical. So I'd like to thank everyone for their attention and now take a moment to introduce my esteemed colleague, Dr. Vivian Moe. She's a clinical associate professor of medicine, the chief medical officer at USC Keck Medical Group, and the interim chief of the Division of Cardiovascular Medicine. So Dr. Moe, please.
Thank you. Thank you for having me here today. I'm just going to talk briefly about aging well in terms of cardiovascular disease. I think many of us know about cardiovascular disease, and unfortunately we know it on the tail end, whether we've suffered from a heart attack or developed heart failure. But, part of trying to treat those diseases is just in the prevention of. And so I think as we move forward, we're seeing a lot more focus on the prevention of cardiovascular disease. Oops, sorry, wrong slide. So as many of you may know, cardiac disease, especially coronary artery disease, still remains the leading cause of morbidity and mortality worldwide, despite all the advances that we have in its diagnosis and treatment. I'm sure everybody on this in this conference probably understands that somebody they know, somebody they love have suffered from coronary artery disease. And what happens with it is that the development honestly occurs really early in life. It's a process that's lifelong and continues over years and decades. And so for many patients who have had a heart attack, otherwise known as a myocardial infarction, they've had probably at least unfavorable levels of at least one cardiovascular risk factor before their cardiac event. And what I mean by that is that they probably had, if they've gone to their primary care physician, they probably had one risk factor that was identifiable that put them at risk for cardiovascular disease. And so really the job of trying to prevent a heart attack is identifying all the risk factors that someone has for cardiac disease, and modifying them. So the risk factors I'm talking about are specifically hypertension or high blood pressure, high cholesterol, also known as dyslipidemia or hypercholesterolemia, and diabetes. Those are probably the top three things that I look at when I'm trying to assess someone's risk for coronary artery disease. Some of the other things that also play into factor is maybe a family history of people who have died young from heart attacks in someone's family. Also, being obese, not just overweight, but being obese, which many of us know is an epidemic in this country. And then finally, tobacco smoking. Even though tobacco smoking has really gone down in terms of prevalence in this country, it still does play a factor in those patients who smoke. One of the other entities that I deal with a lot in cardiology is heart failure. So coronary disease, which are blockages of the heart, can go on to lead to heart failure. The most common reason for heart failure in this country is coronary artery disease, such that if you have a heart attack, part of that heart muscle dies, and then you go on to develop heart failure. And what it is that your normal heart ends up expanding or enlarging, and it doesn't pump as well. In this country, about 6.5 million Americans have heart failure, and currently, the lifetime risk of developing heart failure is very high. It's almost estimated to be 1 in 5 at 40 years of age. I would venture to say that all of us on this conference, except for maybe a person or two, are in their 40s. And so it has very high prevalence. So we want to diagnose it early and treat it early. The incidence of heart failure increases with age as one gets older, and it's the number one reason for hospitalizations in the elderly. So when we look at any hospital that's admitting patients for any reason, heart failure is always going to be the number one reason for admissions and readmissions. Lastly, I think a disease that kind of really affects our aging population is also arrhythmic disease. So coronary artery disease increases with age, heart failure does as well, as does arrhythmic disease. The most common arrhythmias that we see in cardiology are atrial fibrillation. And not only is it common in the United States, it is the most common arrhythmia worldwide. The most common reason for having atrial fibrillation in our country and most industrialized countries is hypertension or high blood pressure. And atrial fibrillation, the reason it can be so devastating is that it carries a 4 to 5-fold increased risk of stroke. So if you develop atrial fibrillation, your likelihood of having a stroke is up 4 to 5-fold. And when you look at this diagram that I've added, what it shows is that your normal heart contracts. Usually it's the top part of the heart contracts and the bottom follows. In atrial fibrillation, there's kind of a really chaotic contraction and arrhythmia going on in the top part of the heart that then conducts down to the bottom of the part of the heart. And this is what can cause heart failure and definitely can cause strokes, because in that kind of dysarrhythmia and the heart not pumping correctly in the top half of the heart, you can develop clot there, and then that clot can then propagate to your head. Atrial fibrillation is associated with very high risk of cardiovascular events and hospitalization as well. So when talking about kind of these disease states that I see very frequently in cardiology, I just want to again go back to kind of the basics, which is to emphasize that aside from catching it, in the primary care setting or in a hospital setting or developing in a hospital setting, what can we do to prevent them from even happening? And so, like I said, kind of going back to my first slide, which is that improving cardiovascular risk factors can lower the incidence of all three of these things, of lowering the incidence of coronary disease, heart failure, atrial fibrillation, even cancer and depression and cognitive decline, which many of my colleagues have already told you about on this presentation. And so again, the most important way to promote cardiac health is to promote a really healthy lifestyle with a focus on lifestyle optimization, looking at your diet, looking at your physical activity, and for most of us that means increasing physical activity, and very importantly to avoid tobacco use. But really getting to know your numbers, such as your cholesterol numbers, really looking at your weight and if it's controlled and within your body mass, within your ideal body weight, as well as looking at cholesterol and high blood pressure. There's also one more slide I want to share. Let's see if I can do it. That didn't make it on. This is my last slide. Let me see if I can share it. And it'll be this slide. So hopefully, not sure if you can see that. maybe not. I don't know that you can. Let's see if I can share again. I'm sorry, I cannot tell. Oh, I think you can see it, though. No, I'm sorry. I do have one more slide. I didn't quite make it up to here, and I'm not sure that I can share it. But what I wanted to introduce to you is that here at USC, what we do have, and we're just newly beginning it, is what's called the USC Cardiac and Vascular Institute. And what it is a kind of a joint coalition between myself in cardiology with my cardiac surgery colleagues as well as my vascular surgery colleagues. So the three divisions that make up and treat all cardiovascular disease, we're actually coming under one umbrella known as the Cardiac and Vascular Institute. And in that institute, we are looking at many aspects of cardiac care: coronary care, valvular heart disease care, which I didn't even touch upon, arrhythmia care, and preventative care, as well as looking at the aorta and looking at congenital heart disease. There's many aspects of cardiac care. I've only brought to you kind of the top three that I think really affect our population. But the USC Cardiac and Vascular Institute plans on offering comprehensive care. And so that's something that we're going to be debuting and really growing in our practice. So I welcome you to visit our website. I'm sorry I can't bring it up right now on this presentation, but if anybody is interested, please feel free to contact me and I will get you connected. And that's, I believe, the end. Thank you so much for your time.
So I'm going to now entertain some questions for our panels. I want to thank each of our speakers for their presentations, which have been really interesting and insightful. I first have a question for Dr. Yassin. What recommendations do you have for taking omega-3 fatty acids in terms of consumption to reduce the risk of Alzheimer's disease?
Thank you, Jenny. It's a great question. We currently don't recommend taking omega-3 supplements if somebody can consume at least one serving of fatty fish like salmon per week. Epidemiology studies actually have stronger data. Those who consume fatty fish enriched in omega-3s, and fatty fish contain vitamins, B12, antioxidant, vitamin E, and so forth, are more powerful. Now, for some of us, either consumption of fish is either not affordable or available, or there are some restrictions, and in that case, it might be useful to take omega-3 supplements. And there isn't really a well-established dose to take or type of omega-3. More research is needed to figure it out. But in case somebody has really no access to seafood, omega-3 supplements might be helpful in particular populations, such as ApoE4 carriers, before they develop any disease, to prevent the development of such disease.
Thank you. And just a reminder, too, for people to continue to put questions into the chat. We're getting some questions, and I want to now ask my colleague, Dr. Humayun. You've been successful in getting new treatments to patients. How do you make this happen?
Well, thank you for that question, Janai. That's what we have to do as physician scientists or scientists working in the medical field. It's really key to take that idea from what we've heard, the proverbial bench side, to patient. And it's very difficult because often, we're in a space that's very regulated by the FDA. So what we have to do is just right from the get-go, when we do come across beautiful and wonderful science and a breakthrough, then we immediately have to start to think, how do we get this through the FDA so we can get to the patients? And we've been, so you have to keep that in mind. And we've been lucky to be able to do that with multiple inventions, including, an electronic chip to restore sight, which is what we got the White House Award for. And then more recently, the stem cell implant. So it's really that understanding that this breakthrough idea really needs to be aligned so we can get it through the FDA approval to start clinical trials and then ultimately get it approved as a product. But yeah, something we absolutely have to keep in mind. Thank you.
Thank you. We have an audience question for Dr. Mo. This is a question about AFib and the use of blood thinners, and how much do they lower the risk of stroke?
Significantly. I mean, this is one of the cornerstones of atrial fibrillation. It's a very complex disease to treat because you not only want to try and get people back into normal rhythm or sinus rhythm, but very importantly is to anticoagulate them. So Xarelto is one of the newer anticoagulants. Our previous anticoagulant choice was only Coumadin, or also known as warfarin. But taking any of these medications, any of the anticoagulants correctly can significantly lower your risk, essentially down to normal population risk. So one of the first things I do when I see somebody who's in atrial fibrillation, I immediately think about whether they can be on anticoagulation to decrease their risk of stroke, because stroke is the most devastating consequence of having atrial fib.
Thank you. Going back to Dr. Yassin, there's a question about a couple of medications that and whether they prolong life. And the medications are specifically metformin and rapamycin. I wonder if you could comment on those.
Sure. So the background of the question is that modulating the mTOR pathway, mTORC2 specifically, in animal models from worms all the way to mice have been shown in elegant studies to prolong their lifespan. And the question is, would that apply to humans? And I don't think we're there yet. We don't have careful human studies, and these are incredibly difficult to do, that shows that either metformin or rapamycin can prolong lifespan. Now, metformin has a clinical use in patients with diabetes, especially in those who are overweight or obese. It has been shown to provide cardiovascular benefit, albeit not a huge benefit, but it is beneficial in patients with both diabetes and obesity. Rapamycin is a powerful medication that could be an immunosuppressant, and certainly wouldn't recommend somebody to take it without clinical advice. So I hope this addresses the question, but there's excitement about translation from animal studies to humans, but we're not there yet.
Thank you. Going back to Dr. Humayun, in addition to the excellent treatments that you are discovering, there's a question about vitamins and helping to prevent macular degeneration. I wonder if you could comment on that.
Well, thank you for that question. And I did allude to that very quickly in my talk. So the vitamins that have been shown to help are for dry macular degeneration. And these are called Preservision or Arids 2. You can get them over the counter. And actually, they're more than just vitamins. I like to refer to them as nutraceuticals because they do have very high doses of certain vitamins and minerals. So they're not just the run-of-the-mill vitamins, the multivitamins you get. But here's the bottom line. You do have to have a certain level of dry macular degeneration for these vitamins to be helpful. So we studied this over a 10-year period, in lots of patients in a study that was sponsored by the National Eye Institute. And only when you meet a certain threshold of these nutraceuticals or high-dose vitamins and minerals help slow down dry macular degeneration by about 26%. So they are very useful, but only at a certain stage, and only a very particular type of vitamin, which is the Preservision Arids 2, that has been studied. There are lots of vitamins out there, lots of claims, but I always tell all my patients that this is the only vitamin that we know of that's been studied by the National Eye Institute, and it only works at a certain stage of the disease and not for any eye disease, certainly for a very specific stage of dry macular degeneration. Thank you for that question.
Thank you. Dr. Mo, I'm wondering if you can comment on heart failure, and given the prevalence, is this something that people should be tested for, or what are maybe some things that patients might look out for related to whether they might have heart failure?
Yes, because it is so common. I think, first of all, people should maybe see what their chance of having heart failure is. So if they've had, say, any of those risk factors, the high hypertension, diabetes, high cholesterol, a family history of heart disease, to be kind of seen by your primary care physician so that they can do a physical exam and determine if an echocardiogram, which is a sonogram of the heart, is indicated. Some of the signs and symptoms of heart failure are people maybe feeling more short of breath than they usually are, whether sitting at rest or maybe exercising. People can also notice that they have a lot of swelling in their extremities, usually starts in the leg. Feeling, kind of just fatigued in general, not as energetic, but really the breathing and the swelling is probably the most common symptoms I see. But I think for people who are kind of general population wondering if they have it, the signs and symptoms will be kind of the first things that come up, but also to know if you have the risk factors for developing heart failure. Because there are medications that we can quickly put you on. Diuretics can quickly get rid of the fluid, but then that means that if you have heart failure, we need to figure out why do you have it. Is it because you have uncontrolled blood pressure? Is it because you have underlying coronary disease? Is it because you recently had an infection? Many reasons to have heart failure, but I think the most useful thing for our population to know is just to know what the signs and symptoms are of heart failure.
Thank you, Dr. Mo. And just a reminder for our audience to continue putting questions into the chat if you have them for our esteemed panel. And I know there are some questions about whether this is being recorded and whether you'll have access to it afterward. And I believe the answer to that is yes. So this is being recorded, but if you have additional questions that you'd like to have answered, please go ahead and put those into the question and answer section. Let's go back to Dr. Yassin, and appreciated the presentation on the genes that have increased risk of Alzheimer's. Is this now at a point where people should be asking to be checked for these genes? I know you mentioned 23andMe is very popular, but is this something that you should be going to your doctor and asking for a test?
If you asked me that question 5 years ago, I would have said no. But if you're asking me the question now, I would say yes. If I had a family history of Alzheimer's disease and I have children and I am, during middle age, I would want to know if I carry gene variants that put me at a higher risk of dementia, because that could change some of the things I do. Although we don't really have very tight and strong recommendations, but we know enough to, advise people on certain things. For example, if you are engaging in contact sports where there is brain concussion and injury, if you are an ApoE4 carrier, the chance of damage to the brain is much higher than if you are a non-carrier. I would advise children or adults engaging in contact sports to probably change those sports. The diet that we eat could probably change to increase the content of omega-3s. Certain things such as taking care of, the oral care, gingivitis, any cause of chronic inflammation is going to be aggravated and more difficult to control in E4 carriers than non-carriers. So knowing your gene variant sometimes could be helpful in preventing a devastating disease like Alzheimer's, because once people have it, it becomes incredibly difficult to treat. And knowledge could be bliss. And in that regards, I guess the answer should be yes.
Thank you. And there's another question that's come in. Are there any other gene variants that are recommended to check for that might be associated with dementia and Alzheimer's besides the one that you had mentioned earlier?
There's definitely a lot of gene variants that increase the risk of Alzheimer's disease. The problem is we need a lot more research to understand how they increase the risk and what recommendations should be based on those gene variants. We're just, this pharmacogenomics and this whole new information of what to do with gene variants is really cutting edge research. And I think with support that we receive from generous families, we can do more cutting-edge research to understand what recommendations should be. Yes, there are more gene variants, but honestly, we don't know what the recommendations would be because we're just touching the tip of the iceberg in terms of understanding the gene by diet, gene by lifestyle interactions.
Thank you. Very, very exciting about all of the continued research that we need to do to build on what we're already learning and the important need for that. Dr. Humayun, I wonder if you could, I mean, we talked a little bit about treatments and even some vitamins that might be recommended once you have early stages of macular degeneration. I wonder if there are any other prevention tips that you would give to our audience in terms of protecting eye health.
Yes, actually there is. It's, as we've been hearing, a healthy heart diet is actually a healthy eye diet. And in particular, what's very interesting is we all, as growing up as kids and even later on, we've always, known carrots are good for the eye. But actually, there's something even better than carrots. And for, in particular, macular degeneration, dry macular degeneration, they're the green leafy vegetables. So, a healthy dose of green leafy vegetables with some carrots, of course, is a wonderful source and is very, very helpful and protective against, dry macular degeneration. So that's something one can do, is to supplement your diet, if you're not already doing so, is to eat green leafy vegetables. They're good for the eye.
Thank you for that. Let me ask Dr. Mo, do you have any recommendations on supplements for the heart?
Supplements, they're hard to recommend. First of all, the thing about supplements, they're not regulated in this country as strictly as they are in other countries like Germany. We do a fair amount of research on supplements, but because at least in this country, they're considered nutritional, there's not a lot of studies that are done on them. But some of the things that I could recommend is for some of my patients who don't like to take cholesterol-lowering medicines like statins, like the atorvastatin, Lipitor, simvastatin, because they think they get a lot of body aches from it. Sometimes we recommend that they take red yeast rice instead, which actually has a statin component in it. But some of my patients tend to do a little bit better on red yeast rice than, say, a prescriptive cholesterol medication. I think also the fish oil is definitely a supplement that we recommend for a lot of our patients with cholesterol issues. But I think some of the other things that you'll see that I wouldn't say they're experimental, but I think largely accepted by the cardiology community, but not so much that somebody would push for it, are things like ubiquinol or coenzyme Q10. We see a lot of our patients taking that, thinking that it kind of increases myocyte health as well, or heart muscle health. But a lot of these things aren't necessarily proven. But I don't know that I would, when I see a patient and I'm trying to prevent them from getting cardiac disease, I can say you definitely should take this supplement. But I'm very open to it. I'm always learning from my patients what they have learned on the, they do a lot more research sometimes than I do about the supplements that they've heard have positive cardiac effects. But I still stick to lifestyle modification, things that I can change, such as improving cholesterol, diabetes, weight, blood pressure.
Thank you. It sounds like you concur with some of our other panelists about the importance of eating healthy, exercising regularly. But red yeast rice, I think, is what I heard you say for maybe for people who don't tolerate a prescription statin. That might be another possibility. There also was a question about cardiovascular screening tests that can help to determine cardiovascular disease. I wonder if you could comment on that and whether those are accurate.
It really we have so much testing that we can do in cardiology. And it really kind of depends on two things. What are the patient's risk factors? So the ones that we've been talking about. And also kind of what their symptoms are and what we call pre-test probability is. What is the likelihood of them having disease that I can detect on the exam? So probably the two most common tests that I get to screen for these things, to screen for heart failure, to screen for coronary disease, is an exercise treadmill test where I hook somebody up with an EKG, and I make them run as much as I can on just a normal treadmill, but this treadmill speeds up and kind of goes up on incline. That gives me a really good idea of whether they have maybe a very occult blood vessel blockage, and it tells me how well they can exercise. That has a lot of prognostic information given to it. It's such a simple test. Many of you probably are runners, and so you're doing a stress test every day of your life and probably passing it with flying colors. The other test I very oftentimes order is an echocardiogram. I'd mentioned it briefly before. It's an ultrasound of the heart. There's no radiation whatsoever. And what that does is it really not only tells me what the heart looks like, tells me, is the muscle coming in, what is the shape of the heart, are the chambers the right size, the 4 chambers, are they the right size? It also gives me information about the valves. We have 4 valves in our heart. Are they functioning properly? And like I said, whether the heart is contracting or not. So those 2 tests, the exercise treadmill test as well as the echocardiogram, very simple tests to do, really no harm to the body. There's no radiation, and gives us a wealth of information. I would actually say that I would use those tests. I don't know that I would screen the general population with it, but those patients that have risk factors that we've talked about, hypertension, diabetes, smoking, cholesterol, overweight, those are the 2 number 1 screening tests that I would.
Thank you, Dr. Mo. There's a question about astaxanthin, if I'm saying that correctly. I wonder if any of our panelists are familiar with that, and if it's helpful for reducing inflammation and helpful for older adults.
So I do have a comment in general about supplements. And, this particular supplement is a carotenoid lipid soluble that's shown on a very small scale to have anti-inflammatory properties. However, we do lack the gold standard, which is randomized clinical trials that can guide us on whether we should recommend it as a general recommendation. Now, that doesn't mean that an individual can try a supplement and that supplement could make a big difference. So we do have to differentiate it on an individual level. Some of these supplements may work on certain people, but as a general recommendation, we do need the gold standard, which are randomized clinical trials, before we go ahead and recommend them.
Thank you. And Dr. Yassin, there's another question for you. Is there any hope with the identification of the ApoE4 gene that this could lead to being able to reverse symptoms if someone or a family member is suffering from Alzheimer's dementia?
Of course, there's always hope. And, at USC, I'm working with the School of Medicine, the Department of Neurology, to build an ApoE4 center, partially clinical and partially research, where we could offer services to ApoE4 carriers and provide them some detailed information using brain biomarkers, lipids, and other measurements so that we can help them at least slow down the progression to disease. And the research component would be focused on developing specific ApoE4 drugs to treat patients with ApoE4 and dementia, because we have learned that there's so much heterogeneity in dementia, and we have to be more specific and identify specific drugs that works on specific pathways as opposed to generalized treatments. So there is hope, and we're working at USC to establish resources for ApoE4 carriers.
Thank you. I think we are at the end of our questions that I see here in the chat, but I'd like to just invite each of my colleagues, if they have a few concluding words to share with our audience. And Dr. Humayun, would you like to go first?
Yes, I would be happy to. Thank you, Janai. So again, the eye is something we so much depend on as we get older in terms of reading and how we get the information. And aging does affect the eye, and I've shared some of the various conditions that it can affect. And please get your eye check once a year, especially if you're in the older category, older population, because the sooner we catch some of these conditions, and hopefully we don't, hopefully you have a perfectly healthy eye, but the sooner we catch them, the more we can perhaps do something about. So please get your eye check. We're happy to see any one of you at the USC Roski Eye Institute, you can call, and we have multiple clinical sites. And when you do come, and if you have interest in any of our research programs, we'd be also happy to share that with you. Thank you.
Thank you, Dr. Humayun. Dr. Mo.
Sure. I think I've emphasized it in this presentation. Right? I think that so much of it is that I oftentimes see patients kind of too late. I think most of us are very attuned to our health, but even I think doctors are the worst patients. We tend to put off our health for quite some time. And so I would always say that, don't wait for something bad to happen. Really try to prevent as much as you can. And that starts with all the things that we've talked about, diet, exercise, leading a healthy lifestyle. Nothing more can be said about your health. We take our health for granted until we don't have it. It's like car trouble. You don't think about your car until, wheel pops off or it breaks down and the world ends for that day. So I really think that, take care of your heart. It will take care of you. And so, if you haven't been screened for heart disease, and I would say anybody over the age of, 45, 50 really should be screened to have it done.
Thank you, Dr. Mo. And Dr. Yassin, any final comments?
Well, thank you all for attending this talk. It has been a pleasure and a wonderful opportunity to present our work. I would just echo all the speakers and say this is an exciting time, especially for the brain. We now have some tools that we could use to look at the brain decades before diseases like dementia happen. And we understand that during midlife is the time to start working on things to prevent dementia, which we see as a really end-stage, late event. With the new advent of genetics, with new, personalized approaches for diet, for lifestyle, there is really a good chance that we could put an impact in diseases like Alzheimer's, but we have to start early, just like Dr. Humayun and Dr. Mo said. And we are building resources at USC to address these clinical and research gaps. And we appreciate your support.
Thank you, Dr. Yassin. And again, thank you to Dr. Mo and Dr. Humayun for your comments and your presentations today and the important work that you're doing. As a family medicine physician, we care for patients and their families in the context of their community over time. We believe in these longitudinal relationships. And as my patients get older, I feel so fortunate to practice at USC, where we have access to cutting-edge treatments and cutting-edge therapies across a range of specialties. And for our older adults who have more needs, it is a really hopeful place to be. So I want to thank all of you for your participation today, for your thoughtful questions. And I want to say a special thank you to the Whittier Trust Foundation for working in collaboration with us at USC to be able to share this information with you. Thank you for your time. If you have additional questions about the work that we're doing, please feel free to reach out to Keck Advancement for more information on the innovative work that was showcased in this webinar. Take care and have a good day.